Good morning, everyone. Welcome. I'm Kristan Uhlenbrock, your host, I shouldn't say co-host, your host for this series on COVID-19 science and stories. We've been bringing you this webinar series now since April, and we are hitting our 20 episode mark today. So you're in for a treat. I've seen a number of people in the chat who have been longtime viewers and followers, so welcome back. If this is your first time, I think you've tuned in for a really great episode. I do want to thank and acknowledge our partners in putting this together, our friends at the Colorado School of Public Health. Dean Samet has been really instrumental in us securing speakers and thinking through all these topics with us. So a huge thank you to him, as well as a huge thank you to my colleagues at the Institute for Science and Policy and the Denver Museum of Nature and Science. We have two audiences joining us today, so just a quick housekeeping on how to ask questions. If you're here on Zoom, you can open up that chat feature. Let us know where you're watching from. We'd love to see that. And that's going to be where you can ask your questions. Feel free to chime those in at any time during the presentation, and I will do my best to incorporate as many as I can into the Q&A that we have towards the latter half of the program. If you're joining us on Facebook Live this morning, the comment feature is where you can ask your question. We have eyes on that as well, and we will incorporate those into our discussion as well. So we are a little more than 6 months in, and since then, our collective knowledge about COVID-19 has altered dramatically. This pandemic has affected every aspect of our lives. And so today we're going to spend a little time reflecting on where we are as a state and the road ahead. We're going to hear about some of the steps and actions that have been made to manage the COVID-19 pandemic and recovery here in the state of Colorado. So a couple of weeks ago, we had that national perspective with Dr. Georges Benjamin, and today we're bringing it home here to Colorado, could kind of do a little bit of a similar analysis and view. I am really pleased this morning to be joined by two guests, Jill Hunsaker Ryan and Kacey Wulff. Jill is the Executive Director of the Colorado Department of Public Health and the Environment and has more than 2 decades of public health experience. Before joining CDPHE, she was an Eagle County Commissioner, served as President of the Colorado Communities for Climate Action, and had previously been appointed to the State Board of Health, among other things. Kacey Wulff is also joining us today. Kacey is leading our state's coordination as the governor's senior advisor for Colorado's COVID-19 response. She previously served as the deputy chief of staff and senior advisor to the lieutenant governor, had also worked for the U.S. Department of Health and Human Services, and was the director of the Children's Movement for Children's Now in California. She holds her master's degree in public health from Johns Hopkins University. So we are in great hands today with two of our leaders here in the state, and they're going to walk us through a little bit about where we've come as a state, and we're going to share slides. And I'm going to turn this over and welcome Jill. Good morning, Jill. How are you?
Good morning. Hi, Kristan. I'm happy to be with you this morning.
Great.
You're in for a treat because I've got a bunch of graphs for you. Why don't I'll start out with just the early timeline of COVID-19 in Colorado. We started seeing it in the United States in January. Our state laboratory didn't actually get the reagents from the Centers for Disease Control until February. And then it turned out that the reagents weren't working very well. And so for a while in February, although we know the virus was here, we weren't able to test for it. Initially, the CDC provided the reagents just to state labs. So there weren't any commercial labs able to do testing for COVID-19. We were able to test by late February, probably the last day in February actually, and we got our first case on March 5th. So this is just a timeline that occurred in Summit County, and within a week we started having more cases that we were identifying through testing. At that point, we really didn't know how many cases were out there or how widespread this was in Colorado. We were flying a little bit blind. We had our first COVID death on March 9th, and that told us that indeed we had cases in February. The very next day, the governor declared a state of emergency. At that point, we were detecting 18 cases around the state. We were really seeing cases up in the mountain communities, and it seemed like with so many tourists coming in, that was probably one major source of the initial spread in Colorado. So on March 15th and 16th, some of the ski resorts closed on their own, and then the governor did an order to closed ski resorts, and also restaurants and bars on the same day. We gave the message that we wanted tourists to go home, to go to their final destination. At this point, we knew we probably had widespread community transmission, and just wanted to get people out of the state. Contact tracing, isolation, quarantine becomes much more complex when you have people who are visitors. On March 18th, we closed the schools. Like I said, it was evident that we had widespread community transmission. We were also starting to understand more about how incapacitating and deadly the virus could be. On March 25th, just looking at how quickly our cases were increasing, the governor issued a statewide stay-at-home order. At that point, we had detected 1,385 cases. We were operating on this model, maybe some of you saw it, an epidemiological model called the hammer and the dance, that was basically saying if you could close everything down and suppress the virus below a reproductive number of 1, you'd have a lot easier time maintaining the suppression through regular containment efforts like testing, isolation, and quarantine, without having to do these major restrictions of everybody in the state. On April 27th, the statewide order was lifted and we went into a safer at home order. At that time, we were detecting over 1,400 cases. So I'll show you what the epidemic looks like today. So when we say daily case count, what we mean is these are the number of cases that the state health department has been able to detect, mostly through testing. And you'll see that we are indeed into our 3rd wave in Colorado. The wave that happened in July was really due to the 4th of July weekend. We were able to knock it back down before it got away from us. We knew that with kids going back to school and universities starting, we were probably going to see an increase. And then we also knew that with the Labor Day holiday, we might see a jump like we had seen in July. And that is in fact what is the case. So we are, as we sit here today, still on an increasing trend in Colorado. Our goal is to knock this down before the holidays start and the winter season comes and the flu comes. So we're working with counties to try and put some additional mitigation efforts in place. So, but I want to show you, remember going back to March where I said that the CDC had only given states the testing reagent and commercial labs didn't have it. What that meant was we weren't able to test very many people. We have a slide in a minute that will show you. Initially, we were testing about 160 people per week. Now we're testing over 20,000 people per week. So we want you to see, this is, if you look at the dark orange, that's the epi chart I just showed you with the 3 waves. Those don't show up that well on here because this is the actual number of infected individuals that the School of Public Health thinks Colorado has had. So this is the true epidemiological chart. They think that in March, we actually had as many as 4,500 new cases per day. And it's why we really needed to do the stay-at-home order. You can see now, since we've got so much more testing, the state lab has increased its capacity. We do 3 shifts, 3 24-hour shifts, and we're able to process about 5,000 tests a week. And then with contracts with other labs, like I said, we're testing over 22,000 people a week. And that's why the actual cases, we're not detecting all of them because of the asymptomatic nature. There are a little over 1,000 cases, but certainly not as much as the 4,500 that we were seeing back in March. You'll see that our hospitalizations follow the exact same curves. So these are hospitalized patients, both COVID confirmed and suspected. And we're showing this to you just because, again, we're starting to see an increase in the 3rd wave. Hospitalizations normally follow about 2 weeks behind increase in cases because it takes about that long before somebody is hospitalized or the illness. I missed my testing slide. And this simply shows you, again, going back to the beginning of March. You can see in February we had no testing. In March we had a little bit of testing, and this just shows the green is commercial labs, and the I guess you'd call it beige is the state lab. And if you have enough testing, then you're really able to use isolation and quarantine as containment measures. Because of the asymptomatic nature of COVID-19, we have to be able to detect when somebody has the illness. Otherwise, they could walk around for 14 days infecting people and not know it. That red line is percent positivity of tests. We want that below 5%. And if you look at the left-hand side of the chart, that shows percent positivity. Back in April, we were up over 25% positivity, and it showed that we just weren't conducting near enough tests to be able to be confident that we were capturing most of them. Our goal is below 5%, and we have been below that and successful in doing that for a while at testing over 20,000 people a day. I'm going to hand it off to my colleague, Kacey Wulff from the governor's office, to talk about what we've learned these past 6 months.
Great, thank you so much, Jill. And thank you so much for having me today. I really appreciate the chance to share. It's pretty stunning when you look at those slides over the past 6 months to see how much our trends have changed. And I'm going to talk a little bit about some of the ways that we've incorporated this information into our policy making and how that's evolved and changed over these past 6 months. I think it's important to, articulate that when the virus first came to Colorado, as Jill discussed, we didn't have tests. Commercial labs didn't have tests. We knew very little about how it was transmitted. We knew very little about, for example, the efficacy of mask wearing. We also knew very little about clinical management of the disease. We had a handful of isolated case studies, but the ability to do effective treatment, clinical treatment, has also changed. And so I think it's important to look at this as much as it is a public health and policy response. It's also been a scientific response. And we have been sprinting to do the scientific work to really ground the decisions that we're able to make in the best available data and evidence, knowing that the best available data and evidence is still evolving and changing pretty profoundly, even week over week. So as Jill mentioned, early in March, we had the ability as a state to be running about 160 tests per day. Now, last week we had about 3 days where we hit over 20,000 tests per day. And that's pretty profound. And what this really shows is our ability to actually detect a high integrity estimate of how much transmission we actually have in our communities has profoundly changed. And this is really important because, as Jill mentioned, without these public health tools, testing, containment, treatment, we really have to rely on things like social distancing in order to do containment. But by being able to do this testing and being able to have a high integrity estimate of what transmission looks like, it means that we're able to more and more start relying on these public health tools. This is a great chart, and it shows you how each state in the country is doing in terms of what the incidence has been in the last 7 days. In Colorado, we've had over 78,000 reported cases total, but we still have one of the lowest incident rates and lowest mortality rates in the country, where we in Colorado have had about 78,000 cases. The country as a whole has had about 7.75 million cases. And so the reason why this is so critical is we really do look at other states as labs. We really constantly evaluate other state policies. We have a wide variety of approaches on how you do containment in states across the country, and we monitor them all really closely. And I think, one thing that I feel really proud about, and I know Jill feels really proud about, is Colorado has consistently been a positive outlier compared to our sister states immediately surrounding us. And, we think that that really stems from the governor's commitment and Jill's commitment and leadership to ground our decisions in the best available data and evidence. We know that there are many aspects of this that are heavily politicized, and that's understandable. This is an incredibly disruptive year, and people are impacted profoundly. However, we do really use our science and evidence as our North Star as we're navigating these difficult decisions. And we think that that's one reason why Colorado has continued to be this, little sea of yellow surrounded by that orange and pink. And so, similar to how the United States is really diverse, within Colorado, our counties are incredibly diverse and our populations are incredibly diverse. And the strategies to do containment in Denver, for example, are probably going to look really different than the strategies in Saguache County or another county of ours. And so what we've been working towards is step-by-step building a framework that really balances that need for consistency statewide with an acknowledgement that our communities are really diverse and there needs to be room for local management. And what we're trying to do is make sure that that level of openness is proportional to the level of transmission in a community. So the more transmission in a community there is, the less open it should be. And the less transmission in a community, the more open it should be, right? And so we're walking this tightrope between making sure that those things are right-sized. And it's really important to have them right-sized because we don't want to be an inch more restrictive than we absolutely have to. From an economic perspective, we also can't be an inch more open than is appropriate because what we know about this virus is that it grows exponentially. And so once it starts to take off, once it starts to go through that curve that we saw early in March, then we know that our public health tools like testing and containment may not be able to contain it. And so what we then have to do is look at these things like extreme social distancing in order to do containment. And that's a scenario like we went through in March and April that we never want to have to go through again. So it really is this tightrope between the two. So we have a framework that allows a county to be in any one particular stage, protect our neighbors being the most open, stay at home obviously being the most closed, and these 3 phases in the middle that reflects this gradient. Each of these phases is defined by a set of metrics around the amount of transmission happening in the community, so the incidence, the amount of testing happening in the community, so the percent positivity. This is really important because you could have an incidence of 0 in a community if you were doing 0 testing, right? So these 2 things, they have to balance each other. You need to be doing enough testing to feel like there's a high integrity estimate of the amount of disease in a community. And the third metric is around hospitalizations, which is really a good estimate of the amount of severe disease in a community. So a county is measured on all of these 3 metrics, and each level sort of has the defined zone of what those metrics are. And if a county exceeds one of those metrics, so say a county exceeds the number of cases, the incidence for that level, what it essentially is like a check engine light. So that blinks on, and what it means is that county has about 2 weeks to pull that metric back down with whatever local tactics they want to do. There may be a certain population, there may be a certain activity, there may be something really specific about that community. Maybe they need more testing, that they can actually look at their local circumstances and say, okay, what's going to get me back into compliance with that number? If they get that number back down, the check engine light goes off and they don't have to do anything else. But if they don't get that number back down, then it's the equivalent of having to take the car into the shop. And what that means is do a consultation with Jill and her colleagues at CDPHE to talk about what state-local partnership can happen to really help that community do targeted measures. And so this is our management system with our counties. We're trying to balance this, the critical importance of local control and really customizing the response in our diverse communities with knowing that there's a statewide interest, because while we certainly govern ourselves based on county boundaries or municipal boundaries, the virus doesn't care, right? And so we need there to be that balance and that interplay. And so that's what our policy framework has evolved to be, is to strike that balance. Oops. So now I'm going to talk about another change over the past 6 months, which is I've talked to you about how we've improved testing. I've talked to you about how we've evolved our framework of containment. Now I'm going to talk to you about one of the key things, which is how we've advanced our ability to really protect our most at-risk populations. And I want to show you this slide, which shows you the number of outbreaks per week based on different settings. And I want to point out this blue bar, which represents outbreaks in residential healthcare settings. And as you can see, in March, April, and even in May, but particularly in April, this blue bar was by far the majority of our outbreaks. And this is really worrisome because residential healthcare, that's things like senior facilities or nursing homes. And so this is where our Coloradans really at some of the highest risk of having a severe outcome with COVID, where they are. As you look towards the right of that chart, what you can see is that blue bar has gotten smaller and smaller. And it goes up and down a little bit per week as there is a little bit of an ebb and flow to this. But what it really reflects is the incredible amount of investment and effort we have made to do containment in those settings and really minimize those settings. You can see that there are some bars like those orange bars that have increased, which is, you know, camps or education or childcare, and that makes sense, right? School was out. Kids weren't in school prior to about September. And so what we can see is where our outbreaks are happening is a little bit of a measurement of where populations are interacting. And what we really focus on is making sure that we're minimizing to the absolute greatest extent possible those outbreaks happening in places with our most at-risk individuals. This little chart that you can see on the slide shows you an estimate of the average outbreak size. And as you can see, there's been this incredible success story of the outbreak size starting really large, around 25 people per outbreak, and the number of people per outbreak has fallen to around actually under 5. So what that means is we're catching those outbreaks a lot faster, and we're interfering a lot faster before they can spread to be impacting, you know, 10, 20, 25 people. And so now I'm going to talk to you a little bit about how we use all of this. We've so far really looked back at what has happened and what we've learned. Now I'm going to talk to you about how we use this kind of information to look forward. So this slide is probably one of our most informative slides that we look at every single day. And what the height of the bar shows you are the number of cases reported in that week. And what that percent tells you is the percent change, did it go up or down compared to the previous week. So the red is when we had an increase from the previous week, and the blue is when we had a decrease from the previous week. And what this lets us know is it lets us know how fast things are changing. And the reason why this is so important is because we know that COVID spreads exponentially. What we really want to do is it kind of starts to spread like this, and then often there's this hockey stick where it shoots up. And we're really trying to interfere right before that shoot up, right before that hockey stick occurs. And so the way I like to think about this is that, you know, if you're driving in a car down the road and you see a car stopped ahead of you and you're going, you know, 5 miles an hour, you're going really slowly, you're not going to be worried about crashing into that car. But if you're going 90 miles an hour down the road and there's a car stopped in front of you, you're going to be worried about getting into an accident, right? And so the rate of change matters profoundly. And so as you can see, at the end of April, we went into suppression and we had, you know, week over week decreases. And then we started to creep up gradually with some pretty profound increases right after our holiday weekend. So that dark red, 42% right after the holiday, the 4th of July, and then that dark red, that 63% right after Labor Day. And so what we're really trying to do is change the trend to get back into suppression and get back into a decrease in the number of cases, knowing that we have holiday weekends coming up. So that's one way we use this to look forward and predict what's going to happen based on the expected current events. This slide shows us the same information, but actually instead of measuring the number of cases, we're measuring the number of hospital admissions. And so this is something that's much less sensitive to the amount of testing you're doing, right? You're going to go to the hospital if you need help, and that's something that we're going to be able to measure regardless of how many tests are out there. And what we can see is, you know, each week we make an estimate of what the long-term curve is going to look like. And so this pink or maybe coral line is what we estimated our social distancing level, sort of what the trend was going to look like on September 21st. That green one is what it looked like on September 28th. And then this black line is what we actually observed. So the two colored lines are our models, and the black is the observed. And what we could see is that that black line was really tracking these two models, and then it started to diverge, and then it started to diverge even further. So what that means is right now, hospitalizations are going up at a faster rate than our models originally predicted. So that's something that we need to pay really close attention to. And then this slide projects this information out over a longer period of time, so we can start to estimate what's going to happen over the next few months, right? We know that we don't want to just be reacting, day to day. We actually want to be thinking about our strategy over a longer period of time. And so what this slide does is it takes the different social distancing levels, so the approximation of what the curve looks like based on the number of hospitalizations, and it projects out what that would look like over time at different levels. As you can see, that green one is about where we are right now. It's about that 50% social distancing. As you can see, that's actually the highest curve on this chart. And the first chart shows you the first two charts actually show you the number of cases, one looking in the short term, one looking in the long term. The third one shows you the estimate of if we had that many cases, how many people would we have in the ICU? And that dotted line is an estimate of the total number of state ICU beds we have without having to go into crisis standards of care, or without having to do to stand up things like field hospitals. And so as you can see, that green line, it actually exceeds the number of hospital beds we have starting around maybe early December. The dotted line is an estimate if we were working at that level, and then that level decreased even further with all the holiday travel. So what that means, and what the takeaway is we're estimating where we are based on our current data and evidence. And then this gives us a tool to say, hey, this is not the level we want to be at. We need to change our policy, we need to change our individual behavior, or we need to change all of the above to get on one of these other colored lines to increase that social distancing level. So this gives us a planning and projection tool to say that if we continue on our current path, we are not going to be in good shape for the holidays. So we need to evaluate what kinds of changes need to be made at the state level, the local level, or at the individual level. And so this will be the last slide, and then we'll move into questions. I just wanted to share this because we know Halloween is coming up. We know consistently every time we have a holiday, we see people interacting with each other. We see a decrease in social distancing, and we see transmission. We just want to encourage everyone to, have fun for Halloween and do it as safely as possible. Get creative with it. Think about how you can have a fun celebration while really minimizing the number of people you're interacting with, keeping your activities outside where it is much safer than being inside, wearing masks, and using all the same tools, the fundamentals that will keep yourself and others safe. Thank you so much. We look forward to your questions.
Great. Thanks, Kacey. Thanks, Jill. Are you still with us? I think we've got Jill for about one more minute, and unfortunately, Jill's going to have to leave us right at 9 today as you can imagine, both these lovely folks are quite busy. And Jill, I appreciate you looking at some of the questions that came in from the chat, but I want you to take one before you leave, if that's okay, just so that the rest of the participants could hear. So we had a question from Meg, who actually is a reporter for the Denver Post, who was commenting on the fact that we saw that second wave tied to 4th of July, and then we're kind of in this third wave. And with the holidays coming up, which Kacey was speaking to, is this a pattern we're expecting around every kind of major holiday and event? And if so, how do we get out of that pattern? So Jill, could you comment on that as your final word before leaving us today? And thank you for your time.
Yeah, absolutely. Meg, thank you for the question. Yes, we do believe that this is a pattern that around holidays, people tend to get together instead of socially distancing. We will be providing messaging and media campaigns starting very shortly around asking people during the holidays to continue to maintain their social distancing and stay home. Of course, wear a mask. We've heard a lot of times that people, when they go to visit their families, even if their family's not in the same household, they're not wearing a mask because they're so comfortable around their family. We still want you to wear a mask for sure. Consider if you have family members that are older or that are otherwise at risk for COVID-19, that you don't visit them. And certainly, if you're having any symptoms of COVID-19, stay home and continue to, with the hand washing and other good hygiene practices. But yeah, we want Coloradans to understand that people's behavior does change around the holidays, and then what that does is increase transmission, and it makes it much harder for us to suppress it and get it back under control. So we need people to be extra vigilant, starting with Halloween.
Thank you, Jill. We appreciate your time this morning. We know you have to pop off, but we've got a number of questions we're going to continue on, and Kacey has graciously decided, by Jill, to handle all of those. So Kacey, you're in the hot seat. We've got a lot of questions coming in, but I do want to ask you a little bit about when you were talking about the check engine light and the various metrics used looking at the county level map for Colorado. And then you said, if that check engine light's on, they got about 2 weeks to kind of pull that metric down, to pull whatever metric they need to down to kind of get back in compliance, or whatever term you want to use, in good standing. I'm curious, with supporting local control, like you mentioned, what are some of the state level resources when you see a local county struggling potentially to contain parts of the coronavirus? What state resources are available to them?
Sure, absolutely. There's really a menu of options. The state and Jill's department does a really extraordinary job of customizing how they can support different communities. So first off, there's technical assistance, right? We get the vantage point of seeing all of our counties and seeing them tinker with what works and what doesn't work. And it allows us to be able to say, hey, did you see what they did over here? Or did you see what they did over there? And really be able to draw from those best practices. So first and foremost, the door is always open for that partnership to say, can we brainstorm what's going to work in this community? The state also has an enormous amount of testing resources that we're able to surge, particularly around outbreaks. And I think this is one of the key things, which is that if you're seeing an increase, first and foremost, you want to figure out where it's coming from. And the best way to do that is to surge testing, because that's going to help you just continue to get a more and more accurate count of where the cases are, how many cases there are and where they are. So that that chart that Jill showed, where the estimated number of cases was really high and then the detected number of cases was low, you want to close that gap as much as possible. The more you close that gap, the more you're going to be able to target interventions to the populations most impacted. Same with contact tracing. That's a similar tool that allows you to understand who's impacted and why, to really get at that root cause. And so, for example, we've seen a handful of communities with high numbers of college students have an increase in transmission. And that's the strategies you're going to use to do containment for that population is going to be really different than a community where the increase in cases is in their, maybe a worker population, right? And so they're just very different. And so I think all of the above, the state helps with technical assistance, with testing, with tracing, and certainly with helping these communities be successful.
Thank you. I may want to pick back up on the contact tracing and the universities. We had some questions come in regarding Boulder County in particular. So let's start there. What have been some, I think CU has been one of the ones that's been in the news the most here, about shutting down county and interaction because of university measures needed in place and the amount of students potentially transmitting the virus. I'm wondering if you could speak to how is that going, and what lessons are we learning from that, and what can we do better? I know some folks who live in Boulder County who've been on here today don't seem quite happy about some of the measures that's been put in place to try to stymie the spread of COVID in Boulder.
Sure. So the Boulder County Public Health Department is truly exceptional and has done really an extraordinary job in turning the trend around. So what we saw is, I think we saw, that chart that I showed you, the percent increase week over week. There was 1 week where we saw almost an 80% increase in that college age population. I mean, it was shooting up. And what Boulder County has done is through a series of local public health orders. So these are orders issued by the county. A lot of those orders were around targeting that 18 to 25-year-old population, that student population, keeping them in sort of a modified form of a stay-at-home, not quite a full stay-at-home, but really modifying that level based on if they were in a residence where we knew there was a lot of transmission. We also know that Boulder City instituted a last call order that, you know, essentially last call orders are a proxy for making sure that people are, you know, as it gets later into the night, particularly with this population, you may see a little bit of less compliance. I think that's something that we all experience a little bit, and that they really doubled down on the basics, on testing, on mask wearing. They stood up 2 new community testing sites, and really all of the above. There's no one single strategy that changes a trend. You have to layer these strategies on each other because each strategy has pros and cons and works better or worse depending on the scenario. But when you use them all together in aggregate, they really change a trend. And Boulder's epi curve has come down, and it's not quite all the way down to the level that we want it to get to, but it is well on its path. And it is, you know, it's really that check engine light that went on, and the check engine light is going off. It really is incredible how they've been able to change that trend.
Thank you. We have a question here, which I actually think will probably benefit a lot of people when it comes to testing, since we have the sources of people who really know that need deep information about what it is testing. So, you know, should someone be tested to find, or should we be testing to find asymptomatic individuals? And then I'm going to combine another person's question here, which was questioning about antibody testing, right? And you know, the person was commenting about the cost of an antibody test. So I'm wondering if you could just take a minute or so to really clarify, like, you know, who should be getting tested, who is being tested, what does asymptomatic people mean in regards to this, and then a little bit about antibody testing.
Sure. Well, it's such a good question. And our tests, I mean, if you just think back to when we had 100 tests a day, now doing 20,000 tests a day, the other thing that's changed are the kinds of tests that we can do. And so, you know, who knew that we would be facing a pandemic with a virus where it's estimated that almost 40% of new cases are acquired from somebody without symptoms. So about 40%, almost half the time, somebody is getting sick from someone who has no idea that they're sick. They don't have symptoms. Either they are asymptomatic and they're not going to have symptoms, so they're asymptomatic but still contagious, or they could be pre-symptomatic. So most people are contagious for about 2 days before they experience symptoms. And I believe, although we want to check with our epidemiologist, I believe that day before you get symptoms is actually when you may be at peak contagious. And so this is so different from any other disease we have, right? Like if you have the flu, you know you have the flu. There is no ifs, ands, or buts. You are in bed. You feel like you've been hit by a truck. Whereas this disease, there is a large driver of transmission is asymptomatic. So what that means is that we need to figure out how we're catching those cases. And one way we catch those cases is through testing. And, you know, for people who have symptoms, we absolutely want them to get tested. For people who have been exposed to somebody, we absolutely want them to get tested, right? Because you could have been exposed, you may not be getting sick. We want you to get tested. We want to try to catch that case. Now, there is a little bit of a push and pull between, you know, we don't want everyone to get tested every day. We just don't have the resources for that. What we really want to do is be testing kind of the right people at the right time. That's going to get easier and easier as we have more tests on the market. You guys may have started to hear about some of these tests called antigen tests. So they're different than a PCR test, which is the most accurate test where you get the nasal swab and it gets sent to a lab. There are some tests that work more like a home pregnancy test, right? So they're sort of the instant sort of point of care test. And those tests are really good. They're a little bit less accurate than the tests that get sent to the lab. And so what we really want to be thinking through is how do we use the right test for the right use case? How do we use the right test for the right person? And so, you know, for people who are workers in nursing homes, for example, we want them getting tested really regularly, because if we have a nursing home worker who is asymptomatic, would have no idea that they're sick through no fault of their own, but if they're working with that population is really at risk and could be really negatively impacted. So what we're trying to do is really use our testing resources to be testing those populations really regularly that are interacting with those vulnerable at-risk populations, testing the people who are symptomatic and exposed, and then eventually starting to build out the availability for that cheap, rapid, quick testing for individuals that maybe have no high risk, have no reason to think that they've been exposed. And so they might not be sort of in that first part, but eventually we want people to have access to tests where they can be testing themselves regularly. Antibody tests, so the PCR test and the antigen test, they look to test to see presence of the virus in your body. What the antibody test does is it tests to see if your body has had a reaction to the virus. And so it's looking for your body's reaction. It's not actually finding a piece of that virus itself, it's looking for the antibodies to the virus. These tests are a little bit harder to interpret. Just because you have antibodies, it doesn't necessarily mean you had it, nor does it necessarily mean that you're immune. There's just not enough. This kind of goes back to the scientific response part, that we are still in the middle of the scientific response of understanding what antibodies are going to mean, and understanding what that will mean for our population. So, I think it's interesting. It really contributes to research if you're interested in getting antibody testing, but I don't think the science isn't quite yet at the point where you could interpret that yourself to say, oh, here's my takeaway from that. It's just sort of an interesting fact whether you have antibodies or not, but it doesn't necessarily mean that you had it, nor does it necessarily mean that you have any degree of protection.
Thank you. You've spoken a few times about the ever-evolving nature of just the science and our understanding of this virus, and policies that are trying to respond in real time and change. I'm curious, reflecting back on where we've come so far, a lot of things have changed. Is there kind of one major challenge that you've seen throughout this that you want to speak to, as far as like, wow, we did not anticipate this, but we're handling it now, or, we're still being challenged with X, is there something there that you've had a chance to reflect on?
Oh my goodness, one major.
Yeah, I know there's 20, but from your perspective, just give us one that you haven't spoken to yet.
Yeah, no, I think it's a really good question. I mean, I think that one thing that really stands out is the governor and the state as a whole. We were really early adopters of mask wearing. And actually, the governor started wearing a mask and started doing press conferences talking about the importance of wearing masks before the CDC recommended wearing masks. I mean, we were really early adopters. But if I could hit rewind and go back, that would have been something from day one, because we really do know that masks are incredibly effective at preventing transmission. There was a really good study that the CDC put out of these two hairdressers in Missouri. So these two hairdressers, they were wearing masks while they saw all their clients over the course of a weekend. And they saw, I think between the two of them, they saw like 100 clients, or maybe it was a little more than a weekend. Maybe it was a week. Both of the hairdressers came down with COVID. And that means that the clients they saw them within the time period when they would have been contagious and they would have been able to transmit it to the clients. Not a single one of their clients got COVID. And that is just stunning, right? I mean, masks are incredibly effective. They are the best economic tool we have. There was a paper done by, I think it was done by Goldman Sachs, that estimated that if everyone wore a mask every time they were in public, we could prevent a $5 trillion GDP drop. I mean, it is the best economic tool we have. And so we talk sometimes about the tension between some of our public health measures and some of our economic measures. We really want to be maximizing our public health impact while minimizing any negative economic impacts. And masks are this tool at the intersection where the more we wear masks, the more we're able to keep our businesses open, because the more we're able to stem transmission. And so I think if I could hit rewind and on February 1st have everyone really understand the importance of masks, I bet that that's one thing that we just hope we learn from and then continue to role model, because now we know. And so as I think to the question earlier, how do we break this boom and bust cycle with holidays? Well, one way that we do it is we really use all the tools we have to do prevention in these settings. So wear a mask, Wear it while you're traveling, wear it while you're indoors with people who aren't part of your immediate household. Keep your activities outdoors to the greatest extent possible. Yes, it gets a little bit colder over the holidays, but here in Colorado, we know that there's no such thing as bad weather. There's only bad gear. So bring the right gear with you, sit outside, wash your hands, and continue to follow the practices that you know. I mean, the fundamentals are going to be true. We know them now. We know how this disease is transmitted, and we know how to really get ahead of that and do prevention around the people we love.
Thank you, Kacey. I think that was actually a wonderful note to end on. I really am appreciative of your perspective and time this morning. Thank you to you. Thank you to Jill for all you're doing and leading our state here. We're very appreciative of your time and your leadership. So thank you for joining us today.
Thank you for having me.
It's been great. Thank you to all of our guests. We had a ton of questions, which we didn't get to, of course, but hopefully we got to incorporate some of them. Thank you for tuning in. As a quick reminder for those of you who've asked, we have all of these recordings, and we also have written recaps if you're not a person to go watch video recordings on the Institute website. Just go to institute.dmns.org. You'll be able to find all of that. We are down to an every other week cadence with this series. It's just a reminder. So we'll be back on October 26th. Correct, at 8:30 a.m. Mountain Time. Hopefully you'll join us back then too. I think Nicole dropped in all of our handles on social media, so stay up to date with us by following us on those channels. Thank you all for tuning in. Thank you to our guests today, Kacey and Jill, and we look forward to seeing you soon. Have a good rest of your week.